So we're continuing to look into older osteopathic literature, taking descriptions from there, displaying it, demonstrating it, and also overlaying or speaking about concepts that I will utilize in some of the videos that I've done in the past and in communications that I will have with people who are interested in the profession. Should we forward just a little bit? So what we're looking at here is a description from Charles Hazzard in 1905. He's speaking about prior to working on the 11th or 12th ribs, what he suggests is to loosen the soft tissues in and around the ribs. So specifically his mind goes to the quadratus lumborum. Now the method that I'll show you here and that he described, I don't know that I would say it is specific to quadratus lumborum, regardless of what people want to say or how they want to rationalize it. When we see the method, I'll talk about this a little bit more, but the idea is that there's a gross motion that's occurring, and it's going to occur between the shoulder and the hip, or the shoulder and the pelvis, regardless of how you want to talk about it. What's really happening, or it's more likely an accurate description, is we're getting large motion of a lot of soft tissues in the area because what we're doing in relation to one another, we're displacing the hip and the shoulder girdle, or the pelvis and the shoulder girdle, or the thorax in relation to the pelvis. Again, however you want to frame that. The reality is what we're doing is we're twisting the whole torso. In doing so, if there is something going on with the quadratus lumborum, we may loosen it. I think what's more accurate to say subjectively with respect to how Hazzard and others may have been viewing this is that, well, the QL's in here, so if I make this move, then I have to get the QL. The problem is when we talk about it, we say this is specifically for the QL and we kind of ignore the rest of the context. Now enough of that. What we'll do is we'll simply look at the method. So because the QL is relatively in here, so you're running from the iliac crest up to the 12th rib, and transverse processes of the lumbar column. What we're looking at and what Hazzard says is you take the up-table arm, okay, and you hold it. Now he doesn't tell you how to hold it, but what I will say is if I'm holding it way out here, like I'm way out here, I can't get to my patient, I can't keep them safe. So what I would say, using the concept of contact as control, I basically put the patient's arm on my side and wrap around, right? So again, I wrap around. Now if I'm here, if there's anything going on with the elbow or the shoulder, I can't control the patient very well, but if I come in close, nice and tight, and I wrap around, right? So a video that I've done in the past, wrapping and reinforcing holds, so I wrap, right? So I don't even need my hand, I can move the patient, I can grab my shirt if I feel like it, I might slide on the patient, but this way I've got contact between my arm and my body, so the patient's trapped there, and then I wrap around more, so I've essentially spiraled around the patient's arm. So what Hazzard says is to pull the shoulder forward, have the hand in and around the anterior iliac crest, basically walk away. So what I do is I push the pelvis backwards, pull the shoulder forwards, right? So what we get is relational motion. So the shoulder comes forward in relation to the pelvis. So if I just let the pelvis still, we get the shoulder coming forwards, pelvis staying still. So the shoulder's coming anterior to the pelvis. If I simply push the pelvis back, then the pelvis goes backwards in relation to the shoulder. So the motion is the same. Now if I want to exaggerate it, and I'm more likely to get all of the tissues basically in between shoulder and the pelvis that may be of interest to me that could affect the 12th rib or affect the lumbar column, then what I do is I push back, pull forwards, right? And depending on the patient, I may need to exaggerate this more and more. The idea that's going to guide us is going to be the barrier concept, so go as far as the patient's able to. Now, because I'm not touching the tissue, I'm on the pelvis, I can't tell how much tension or tone is in it, right? Now this is a method that might be very hard on a practitioner because I'm very far away, I have to twist, I have to lean. Okay, so that's the first thing he says, pull the shoulder forward, push the pelvis backwards. The next thing he says is to walk down towards the pelvis because you're going to be closer to it. So you're going to put the patient's arm on their side. Now you just essentially reverse the parameters. Shoulder goes backward, pelvis comes forward. So I can pull the pelvis forward, or I can push the shoulder backwards, or I can do both at the same time. Now in a situation like this, if we're curious about the tissues that would essentially be in the range of the erector mass, the thoracolumbar fascia, the QL. Now I don't think you're ever going to feel the QL very accurately because it's deep. Some people will say you can come from lateral to medial, kind of dive under the erector mass and identify the QL. I'd say that's a dubious claim. But if I've got all of this tissue on tension in some way, shape, or form, it's very likely that I've affected the QL. So it's essentially stretching by inference, might be a good way to say it. But again, without just overcomplicating this with words, the method looks simply like this. Right? I push backwards, push backwards. Now in some cases what you're going to notice is the patient's arm's going to start to kind of slide. So you can kind of cradle and lean here. So if I pin the patient's forearm to them, I can push on the forearm. Right? Now this way I'm not pushing on the ribs or the anterior chest wall. I can just do that. Now, and then instead of pulling back, I can hook, I can control the patient more, contact is control. Going back to what I was saying before, I can, depending on the size of the patient in my hand, I can wrap around and grab onto the erector mats, more or less, so I can palpate it. But here, this is what he's talking about. Pulling forwards, pushing backwards, again, relational motion. Shoulder goes backwards, pelvis goes forwards. So you get things moving in relation to one another. That's the essential method that he's describing to work in and around rib 11 and 12, or prior to working on 11 and 12, ribs 11 and 12, by loosening the quadratus lumborum. What's probably happening again is you're getting, in a large fashion, all the tissues in the area to soften up so that they're not grabbing as much, including iliocostalis thoracis, right? So you're looking in that region, or an iliocostalis lumborum. But again, you're not going to pick those apart, you just move in a grand fashion. So instead of simply saying this is for QL, I wouldn't necessarily agree with the description Hazzard gives. I would say I'm working soft tissues in the region that would span from the pelvis to the thorax or to the rib cage. So pulling forwards, pushing backwards, pulling forwards.